For my field placement, I have been placed at Carrier Clinic through Hackensack Meridian Health. The placement that I am at is at the place that I also work. I work on behavioral unit, but I intern on a more intense unit. It's called IRTS, which stands for the Intense Residential Treatment Service residential type. It is the highest residential that you can go to right after hospitalization placement. It is meant to fit the severe suicidal and homicidal youth of New Jersey. It is the highest of actually these highest types of programs because it is the only locked facility in the entire New Jersey. So we get a lot of elopers who are going to other programs and just not fit there because they just keep running away. So since we're locked, we get a lot of those. It is meant for 13 to 18, but really 13 to 17. But we don't, when you turn 18, we don't just kick you out. I think they keep them until they're 19 years old. And recently we just got a 12-and-a-half-year-old. It got like overrided because of those certain reasons. We've gotten a lot of like abuse situations. Again, a lot of suicide ideations when you come to the IRTS programs. This unit's called SWAN. When you come to SWAN, you have a long history of hospitalizations, whether it's from running away, whether it's hurting somebody, hurting yourself. It's just a long history, and it's like a lengthy thing in order to make it to this program because there are lower levels. I work at a lower level. But it's meant for this 13 to 17-year-olds, and our unit's the only unit that is multi-gendered. We have both males and females, and then transgender individuals as well. So like I said, it's a locked facility. We do a lot of therapeutic work there. We have an ally team who runs groups. It's skill groups, it's sports groups, it's drama, acting, it's art. So they get a whole bunch of wide ranges of groups throughout the day. They live there. They have a school on campus, so it's a lot. But they also, with their program, unlike the hospitals, they get to go on trips. They go clothes shopping. They go to dinner. They like to go to Chick-fil-A on Tuesdays. But they also get to go on passes where they get to go off the campus with their family or DCP&P, whoever is in custody of them. They get visits to a lot of their CMOs are involved. They come all the time. They have CASA workers that come all the time. And the way it works with SWAN is there's phases. So when you're in phase 1, it's like a standard, like you can't go off the lodge. You have to stay on the unit all the time. You can't really go do much. Then they have a phase 2, where you're allowed off the lodge. You're allowed to go to PA, which they go to the hospital side for PA. And they go off for dinner and stuff like that. So they have a lot more like freedom that way. Phase 3 is what gets you to go on trips. Phase 4 is something that like rarely anyone ever makes it there. It's not really like a mandatory thing. But when you're discharging, some kids will make it to phase 4, which gives you like a little more freedom because SWAN specifically is very limited when it comes to stuff. You can't have shoelaces, no strings. They have wireless earbuds for their MP3 players. It's basically like the same setting you would have in a hospital, just a little less. So what I've learned about myself while working on this unit is really my love for advocating. I advocate for both myself, my residents, my staff members that I work on the floor with, especially now that I am a little closer with leadership. I feel a need to advocate for the floor staff who don't feel they have a say and get frustrated with things and want to see things differently. And since I am a floor staff, I do feel passionate about some of the things that they say, so I do advocate for them. I've done a lot of advocating for the kids. Obviously, it's something that I really like doing. But yeah, I think that's one of the things that I really learned about myself, and I didn't really realize how much advocacy work goes into things. I also really love doing sessions with the kids. I always thought that therapy was something I want to be doing with my life, and now being in a placement where I am doing therapy, I'm having a lot of fun, and it's becoming something that's more natural than being like forced to. I am doing a lot of learning, but I do think I have the ability to just do what I'm doing. Even today we had a crisis, and one of my kids, not therapy, on my floor unit, one of the kids was going through a massive panic attack, and I pulled out the color scale to like define the rainbow around the room, and she was able to calm down and regulate herself. So I think it's just coming to my brain now. It's just something that's becoming second nature, which is really cool to see. And then with my professional identity, I think it's really cool. I like to say that I shapeshift. So this right now, with my hat and my little buns and my t-shirt, this is my work uniform. This is what I work on the floor with. I wear sneakers. I wear comfortable pants, because when you're in like a crisis, you got to get down and dirty. You got to be able to be on the floor. I also goof around a lot with my kids. I'm a lot more relaxed and goofball, really. I call myself a school counselor, like a camp counselor, because that's just the way I act on the floor. Obviously, I have the ability to like be stern and redirect them, but that's just how I am on the floor. Just totally different persona. But when I'm interning, I wear my nice clothes that I love, because I finally get to be out of my work uniform that I feel like I'm in 24/7. But I get to be out of my work uniform, and I get to dress the way I want to. I don't have to wear fancy things, because that's not really the kind of facility that we're in. It's more a relaxed fit, but I still like to like dress a little more than I would here. Like I could wear my t-shirt to my internship, but I really don't like to, because I like the chance to wear fun outfits. And my hair is down, and people always look at me and they're like, wow, you can really switch it up here, because it's just the way that my personality changes when I'm interning. It definitely, like, I throw on that professional hat, and I'm not as goofy and stuff with the kids, and my internship unit is totally different mentality with me, and it's the reason why I'm not allowed to work on my internship unit, because of the rapport and the confidentiality and all these other things. So when they see me looking like this, they're like thinking they're going to get like the fun Julie moment, and I hate having to break that like boundary with the kids, so I'm not allowed to work on that unit actually, just because there's such a difference in the way I interact with the kids when based off of where I'm working for the day. So you asked us to describe 2 theories that we worked with. One theory, I use a lot of dialectical behavioral therapy with these kids. I feel like it's a very interactive type of therapy skill to use with them. I also think it's very good because we're in a very heightened state on the unit a lot. So like my one resident that I have, I only have one at the moment. She gets overstimulated a lot. So when she gets overstimulated a lot, she acts up a lot. And I've been working with her with the grounding skills, through DBT. I've been pulling it from there. We just were working on, accept skills. We were working on like the rainbow technique that comes from it, and the 5 senses technique that comes with all these like mindfulness kind of skills that I can pull together and like work with her. I also use the stress tolerance, because my resident also deals with a lot of anger. But I use it in my groups. I have an anger management group. I want to run with them pretty soon. I use the mindfulness techniques from DBT to run our group on Friday, where we have Find It books. And we sit there and we listen to peaceful music, and we work on the books, and it's just we're able to like recoup after a really long week of going to school and doing all this stuff, and just like a mental reset for the weekend. So I do a lot of DBT with the kids. I love using strength-based perspective. I go into my sessions with my resident and being like, okay, what do you want to bring to the table? So I let her get out whatever she wants to get out first. And I mean, it's a 45-minute session, so I can't like sit there and just talk about nonsense all day. But I give her the opportunity to tell me like, how did your day go? And like, where do you want to go with this session? If it's not going in the way that it should be, I will direct it to more therapeutic And there are some times that like I will be like, okay, this is what we're doing today, because I have actually things I need to be doing with her. But I find when I let her do it, I get more out of a session. And with like strength based, with this coping skills, I let her like kind of like feel out what she wanted to do. On Wednesday we went over the skills, and then on Friday I gave her the chance to like think about it, and we made a list of like, okay, I gave you a whole bunch of skills, like what do you think is useful for yourself? What do you think you can see yourself doing? And then we made this list. Now for Friday coming up, we're going to go over, and she's going to discuss what skills worked for her. I have a whole like a log of like your feelings before the coping skill, the feelings after, so just like the problem solve, what's going to be working, what's not going to be working for her. But I like to let her choose. I like to let her choose the direction of where we're going for the day. When I see that she's becoming frustrated with something, I don't want to over push it. So I take a step back. She really struggles with her mom. So sometimes it gets really like a lot for her to like process and stuff. She's a very strained relationship with her mom, so sometimes it becomes a little difficult. I also think of person and environment when I'm dealing with the skills. I have the behavioral unit that I can run paperwork groups with, where we're reading papers and processing and like doing all that type of like heavy work of a group. But I find the ones on the SWAN unit are a little more like developmentally not fully where they should be. I know we have one who's on the spectrum, and we're kind of like problem solving with my own resident that we think she might be on the spectrum. So it's like a little different. Where I run more of a hands-on, like interactive type of group with the SWAN kids, rather than, I work on Eagle. So rather than Eagle, I can do like a firm type of group with them, and they're able to sit there and read through the groups and process the groups. Where on SWAN, if I did a paperwork group, they get distracted very easily, get very disinterested, and it's not effective with them. So I think about where they are in the state that they are. I also know if it's been a long week of crises and stuff, I won't do a really big, heavy group. I will keep it light. That's why on like Fridays, I know it's a long week and they just need a second to just breathe because they had a long week of doing stuff. So I run a light-hearted group. When I see that there's a state of crisis on the unit, like for the whole week, I don't want to overdo and add more stress to them and put them in the group that I know they're not going to be fully functioning to actually sit there and process her. So when it comes to ethics and values, there has been a specific case on the SWAN unit that's been very challenging for me to like think about social work wise. So this is a child. She is 16 years old. Through DCPMP, she was in custody of DCPMP since she was 8. Her mom was very abusive, used drugs, and very manipulative, so she was taken out of the home. She has really no family. She has a grandma, but very, again, strained relationship because of the fact that she's very physically aggressive. She hurts people a lot. She's a really big runaway, so she came to us as like a last resort. They were like, we don't know what to do with her. She needs to be here. But in the meantime of her being here, she's assaulted multiple people. She's had staff members out for a really long time because she causes physical harm to them. She has charges on her pressed by one of the other residents because she jumped her. Charges from some of the staff members. Like, it's just becoming a lot. She also recently smashed open one of our doors. It's got like a glass window that leads out. She smashed open the door. She ran straight through, cut all over her body to elope, to just run. We asked her, like, where are you running to? She has no clue. She just is running. She's so impulsive. But she's very physically aggressive. So because of her aggression, my facility has decided that they no longer want to keep her as a resident, which is very upsetting to me based off the results of what's going to happen. So we go through CCOS, which is the Children's System of Care Center, whatever, something along those lines. We go through that with them, and they're called JCRs, so they do them every single month. And for the transition JCR to a new program, you have to file it, and they like come back to you, let you know like where you think they should be, where do you think is the next good placement for them to go to. And this one basically came back saying, we have nowhere for her to go. They're saying that she exacerbated all of the lower resources that she deemed that she's not fit for, obviously, because she's very aggressive and doesn't fit for lower level of care, that we're at the highest level of care and this is where she needs to be. That she can't be in a non-locked facility because she keeps running. Obviously, she tried running from our program and we're locked. There's been instances of her just beating doors down to the point where like she can escape out of the door. So they're basically saying that, sorry, we have nothing for you. And my therapist is in the thought process that, so right now she's going to an intermediate hospitalization program, which is basically like we call it the AU, the adolescent unit. Basically the same thing, but it's a long-term stay hospital. I think she's going to Trinidad. So I believe that's where she's going. But after that, where are you going? It's not a residential. It's a hospital stay that's just long-term. But typically they stay there for when like they're waiting for a bed for something. So if they're going to another IRTS program, they'll stay there until they can get another IRTS program. So she's being sent there because it's a locked facility. It's the only locked facility I can think of. And I became very upset over the thought process that she has almost been failed. My therapist thinks that they're going to send her out of state. But if you send her out of state, DCP&P will then wipe their hands clean of her and set her up with the state's DCP&P, the new ones. But the issue is then she loses all of the bonds that she made with her CASA workers that she's had since 8, and her CMO and worker, and all of these people that she's actually built a relationship with after her mom. She's going to lose them all, and this is going to become something 10 times worse. But I got upset knowing that Carrier is the last resort when it comes to these kids. The only locked facility. The IRTS program is the last resort for these kids to go find hope. And it's upsetting to me because there are 3 state psychiatric hospitals for adults to stay in. Some of them live there. Some of them stay there until they're gone. Some of them don't. It's court ordered. That's just the way it works. But then there's also a forensic psychiatric facility for criminals who are also psychiatrically need to be cared for. And I thought to myself, and I was like, how come they don't have those types of programs for kids? Obviously, adults' behaviors stem from maybe a young age. Maybe they don't. Maybe like I don't really understand. I don't work with adults. But obviously they get there somehow. My thought is, how is there only one locked facility? How is there only one last resort? Why aren't there multiple other results for people to go to? Why aren't there other locked facilities? And we're attached to a hospital, and I get that we're attached to a hospital, but like Rutgers has a psychiatric facility for kids. Like, how come they don't create a residential side over there? Like, why is nobody developing more resources for these kids to go to? Because what are you going to do with a kid when you no longer have resources? You can't just wipe their hands clean and leave them on the street. You're not allowed to do that. So then you have this thought that this kid's just going to get passed around because no one's able to care for her. But is it that no one can care for her? Is there's so many limited resources in the state of New Jersey, in the United States? I don't know really about other states. But how is there only one locked facility in New Jersey, but there's 4 psychiatric state hospitals for these adults? Why are we having so many placements for these adults, but only one location for these kids to go to when they need help? Because how are we going to care for these kids and expect them to be grown adults in society when we can't care for them? Because then that's how you get places. Even when I think of like juvenile detention centers, they call them JDCs at my job. Why are we just throwing kids into JDC when some of them are coming to us? They come to Eagle a lot from JDC, and they're proving it that they can get better with the therapeutic help, that they don't need to fit this system. So they're showing it. There's proof from these JDC kids coming to the program and getting better and being able to leave and go to treatment homes or go home or group homes and things like that. So these kids are proving it. Why is the government thinking, okay, maybe these JDCs need to be more therapeutic wise than like criminal? They're kids. I think they deserve the help that they're getting, but now we're kicking this kid out of this program, and she has nowhere else to go. She doesn't deem fit for JDC. She's more psychiatric based than it is criminal based. But she sees herself as someone that will make it to the state psychiatric facilities, and it's very upsetting to see her have that persona and like her thought process. But if that's the case, where are you going to put her for now? Because you can't just leave her on the street. And that's just an ethical thing that's going on in my brain recently that's becoming very like frustrating to me. It's very upsetting and frustrating that the system no longer has a place for this child to go to because we just simply don't have the resources to put her somewhere. If we had more locked facilities, this kid would have more of a chance to go somewhere. There should maybe be a forensic facility for kids. I know we don't want to put labels on kids. I know that's also an ethical decision that people don't want to put labels on kids so that they aren't stigmatized that way. But sometimes I guess maybe it's necessary to put a label on a kid if it means getting them help. So I've been thinking like forensic psychiatric facilities for kids. Maybe if they really need them. Maybe if it's really something psychologically happening that they're acting out the way that they are. So the only thing I can think of when it comes to cultural humility on my SWAN unit really comes from the culture of going through DCP&P, I want to say, maybe. A lot of these kids come from DCP&P, they come from trauma, they come from abuse, and it's like a culture that way, I want to say, like related to kind of. I get taken back a lot by the stories of some of these kids. They're only, the 12-year-old that just came to us has been sex trafficked so badly that's why she's in this locked facility now, because they don't want her running away and going back. We have another one that has a case going on because he's finally opening up about these grown men finding him as a kid and coming into the house and just abusing him because his dad wasn't taking care of him, so he was reaching out to other people and they were taking advantage of him. And it's just a lot of those types of stories are what I deal with on SWAN. And you have to think of like the poverty that they come through. We have one individual kid that comes from Camden, and just the family doesn't even have the resources that I sit through the treatment meeting and the dad's like, I wish I could leave Camden. I wish I can give her a better life. I can't. I don't have the resources to leave here. This is what I can do for myself. And it's like, I'm sorry that this is what I have for my child, but it's nothing else I can do. So there's a lot of like thinking when it comes to that type of stuff. And a lot of like reframing my own thoughts, especially Thanksgiving is coming up on Thursday. It's my second year working Thanksgiving on the unit. I won't be home for Thanksgiving again. And it did a lot of reflecting. I was talking to my boyfriend earlier in the car about how grateful I am to have the family I have and the support I have and being able to go home and see my mom. And there's so many kids that don't have a mom or dad. They don't see their siblings. They have family, but they can't go home for Thanksgiving. They have to be in this facility, and the food's not really great for Thanksgiving, so it's not much of a Thanksgiving. Although we try a lot, but it's just not the same. So there's a lot of humbling at my job when it comes to like cultures like that. A lot of reflecting, a lot of like, wow, this is what people go through. It's not my norm, but it's sad to see that it's other people's norms. I did a lot of talking with the Eagle girls when they say certain things to me, and I'm like, we're here to teach you that your norm doesn't have to be your norm. That there are skills that are better for you and that are healthier for you and will be able to serve you in the long run. A lot of my girls on Eagle come from, again, that abuse. We have a 13-year-old that was taking care of her 7 siblings when she was 8. And again, just abuse after abuse after, whether it's food neglect or sexual abuse, emotional abuse, physical abuse. We had one kid come back from past and her mom bit her so bad that it left a mark. Like a grown woman bit the 14-year-old. So just like realizing where these kids are coming from, and in my brain it's always been like that's like a movie, like that could never happen. And now we have these kids coming to us in the state of New Jersey, and some of these kids aren't even in like the poorest of the poor areas of New Jersey. We have kids that come from like Long Branch, that like all like nicer areas, and sometimes too, that just like how does that happen? Like it's just it takes a toll. And you have to also realize, like, I have to put my own self aside sometimes, again, because I didn't grow up with that. I can't relate to the poverty and parent abuse that way. But I don't want the kids to know that I come from better. I don't want them to realize that, because I don't want to lose the respect I have from them. I don't want them to think that I'm better than them. I don't want to think that they don't have someone to relate to, because I can relate to them on certain other parts. I mean, I've been bullied so badly. I've been hospitalized several times. I've had those suicidal feelings and the self-harm, and like I can relate to them on those parts. And again, they can't know that, but I want them to feel it. So I don't, what's the word I'm looking for? I don't let my culture get in the way of seeing their culture, nor do I let my culture get in the way of how I deal with them. I don't let them get my values be in the way of caring for them and meeting their needs that way. I don't think it would be fair. To be completely honest, I don't think my supervision is like top-notch supervision. I work so I work in a group of 2 other therapists. One of the therapists on our unit was on maternity leave. She comes back in January sometime. So I've been working with Jess and Sam. Jess is a licensed counselor. Sam is a LCSW. So I primarily work with Sam, because she knows more, obviously, of like the social work things and everything. But I work a lot with Jess. Jess and I are actually sharing the resident that I have. So I do a lot of like casual supervision with them. I do a lot of leaning on them. I do a lot of reflecting with them. I process a lot of my stuff with them. But it's not what I thought like supervision would be. I don't think I ever like experienced what I thought true supervision would be, even in like my bachelor's internships. But I do clinical once a week, but it doesn't, I feel like I do a lot more supervision with just the LCSW Sam that I work with. I think I get a lot more feedback and connection, because the clinical supervision that we do is a group. It's a group setting with all of the therapists and everything. And we don't get down to like the nitty gritty stuff. I have a higher up LCSW. His name is Tim, but he's like one of the administrators, so he doesn't really do therapy work anymore. I obviously can utilize him if I need him. I utilize Denise is oversees all the therapists and stuff, but she's also a counselor. But I connect with her pretty well. The supervisor for the entire SWAN unit is a social worker, so I connect with her. My supervisor for my EO unit is a social worker, so I connect with her. There's a lot of social workers I can connect with, but I don't want to say it's like an actual supervision, sit down, have a meeting, go over the things. Like, it's not like one of those type of things that I thought supervision would look like. I think it's definitely more of like a casual type of supervision that feels more comfortable, because I feel like I can go to them more often, and not have to wait for the following Tuesday to actually sit down and talk to them. I can walk into their office whenever they need. I can turn my spinny chair around and just talk to Sam about something when I have a question. Like filing paperwork if there's something I'm confused about. Even if there's other therapists on the other units, obviously, that like if Sam and Jess aren't available, I can easily just go over to the other ones. There are some LSWs around as well in the other sections of the offices that I can lean on. A lot of the, well, not a lot, almost all of them, the supervisor of each unit, like Emily's the Swan supervisor, Lauren is my boss, who's the Eagle supervisor. They all were also therapists, so they also all know exactly what I'm supposed to be doing and how to help me. So I do feel like I have a lot of support and a lot of help. I just don't think I would consider it like a supervision sit down meeting that I thought walking in here that that's what I should be doing. But I do think the way I'm doing it now is a lot more effective than I sitting down with someone once a week, because it's just real time fixing things. It's real time. I'm having a problem. Can you help me fix this? Or I'm thinking this thing. Can you sit down and process it with me? And they're able to, because it's a freer space that way. I think I truly love where I am. I love my job. The Eagle unit. I get a lot of positive feedback with my therapeutic approach I have with these kids. We have a lot of staff members that like struggle with the kids with like disengaging and not yelling back at them and not meeting. They do a lot of like, if you're going to yell at me, I'm going to meet you where you're at. I don't. I take a step back. I have a calm approach. But I do love my job. I'm there all the time. I feel like I live there. If I didn't have a plant to care for in my bedroom, I would be there all the time. And I do. I love it can be a very high and intense, stressful job. Like today we had 3 kids almost get into a physical fight, who was bursting in tears. The anxiety attacks, I was talking down because there was just so much chaos today. I was there at work a lot longer than I was supposed to. And that happens a lot when there's a crisis and stuff happening. I get stuck there sometimes. The other day I worked a 16-hour shift. Like it just, sometimes it happens that way when my shifts were technically they're 12 hours. But when I started, they were 8 hours. So it just keeps moving along. But I do love my job. My boyfriend tells me I work too much. And he's like, Julie, maybe you should switch jobs. I'm like, no, but I love my job. Like I am happy where I am. And when it comes to the internship, I'm even happier because I finally feel like I found a home. I have therapists that I connect with. I have my supervisors that I connect with. And for the longest time with the floor staff, with Eagle and stuff, I was struggling because I didn't think I connected very well with the Eagle staffing, like the one on the floor with me. I felt like I came from a different place from them as well. I'm also racially the only white person on the floor. That also caused like a little barrier between me and my coworkers. At least I felt like that way, especially when I started. It was a little difficult. But even now, falling into this therapist role, I really feel like this was what I was meant to do. I told myself when I was like 15, going through my own mental health problems, that I wanted to be the therapist that I never received. I felt like I got failed a lot. While I was in the psychiatric facilities, I was even a patient at Carrier Clinic over 7 years ago. I think October surpassed my 7-year mark of being there. No, it was 8 years. That surpassed. But I came from a long way, and I've been determined since I was little that I wanted to be a therapist. And I think I'm proving to myself that I was right, that I found a passion that I'm good at. And I could see myself staying here. There's some ethical things I think with my job and the therapist role and stuff that like, I think all jobs would have the same kind of mindset. I always thought about how much I love psychosis and like schizophrenia and bipolar, and they have the Earth House in Somerset that's like right around the corner from us, but that's adults, and I don't know if I want to go the adult route, but it's bipolar and schizophrenia specialized, so that's really like the mentality criteria I want, but not really the population of adults that I want. They even mentioned to me it's called the Living Room, which is a substance abuse program residential for teens, that I always thought was a cool idea. Again, substance abuse is not something I'm specifically into, but I definitely think even coming out of my range of working in this behavioral unit, I've fallen in love with certain things that I didn't think I was going to like. I definitely don't think I want to intern, like be a therapist for behavioral. I don't think I have it in me. I think I have more of a connection with mental health with like SWAN and stuff. But it doesn't feel, I don't want to say it doesn't feel like a job, because obviously it does. You do a lot of work, it's a lot of paperwork, it's a lot of groups, and a lot of planning. But I genuinely have a lot of fun. I come home and I have all these elaborate stories. My boyfriend's mom always loves when I come over their house on Thursdays, and she's like, what else you got new for us today? And I do think I work a lot. Some days I work Tuesday through Sunday. Some days my only days off are on Monday, but then I'm doing doctor's appointments, and I'm going food shopping, and then I'm doing homework, and it's never a day off. So I've been really trying to like focus on my self-care this semester, and it's working. But I think I really found the place that I want to be. Professional wise, I'm having a lot of fun at my internship. I'm building the relationships that I want. Even with the therapist, I'm really connecting. I'm finding the people that I think I belong with. And I really think I'm good at what I'm doing. I get a lot of positive feedback from the floor staff who sit through my groups and say they're so much fun. I ran a group with fondant, doing the 5 senses, and one of the guys who's there is doing his practicum for his I believe it's a counselor degree. Don't quote me on that. But he was like, I'm gonna steal this from my groups that I have to do with my kids, and I'm like, go ahead. Like I'm doing a lot of like collaborating, and I'm thinking of all different ways to teach these kids about self-expression and different ways to like see things. I'm also the only therapist on SWAN that actually is running groups based off of because the third therapist is no longer there for maternity leave. They have extra kids, so I'm running the groups, and I'm getting a lot of positive feedback on my groups and the creativity that I'm throwing in there when it comes to things, to the point where they want me to run more groups. Now Wednesdays and Fridays. I was just doing Fridays, but they want me to start Wednesdays as well. And then I'm bringing what I'm learning in therapy, my internship, and I'm bringing it to Eagle. I'm doing the same stuff with Eagle, and the therapists are loving it over there too. My supervisor's loving it. She's always telling me, she goes, oh, I love having a clinical intern as a floor staff. Like it's carrying over to my work unit. And I think I'm where I'm supposed to be.